Which indications can I treat with my Dp4? Let's look at all things epidermis. If there is a malfunction of keratinization, we're going to see things such as milia, but would you believe that this can also contribute to retention, hyperkeratosis, which is the fancy term for clogging and congestion of the skin. And when this follows with infection, we're now going to see acne. Stage 1 comedonal, stage 2 papulopustular, and stage 3 nodular cystic. You can treat acne, active acne, with a Dp4. Aren't you going to spread acne bacteria from one part of the face to the other? Let's have a look at this. So, this is my interpretation of a follicle. It's not a very good interpretation, but outside the side of the follicle, we have a sebaceous gland. And within your sebaceous gland, you have a specific type of cell responsible for the production of sebum. And this is called a sebocyte. So, your sebocytes are responsible for sebum production. Sebocyte equals sebum. The recipe for sebum, if you ever wanted to mix some up, is exactly and precisely 57% triglycerides. A triglyceride is a base oil. Olive oil is a triglyceride. So chemically, it's got 3 chains of glycerol. Sebum also contains 25% wax esters. So a wax is still a lipid, it's just not chemically an oil. What's also contained in sebum is 15% squalane, a lipid, but not chemically a wax or chemically an oil. And then we have 2% cholesterol esters and 1% cholesterol. That's a pretty exact recipe. It's not 56% triglycerides, it's not 58% triglycerides, it's 57%. Who's responsible for making it exactly 57%? Well, it's the bacteria that's also responsible for acne. So the traditional name for this has been P. acnes or Propionine Bacterium acnes. Unfortunately though, this name underwent a slight change in 2016. So the official term for this these days is called Cutibacterium acnes. Cutibacterium acnes lives and thrives in every sebaceous gland. And as such, it's responsible, firstly, for the refining of sebum to make these triglycerides exactly 57%, but it's also responsible for another byproduct that is called a lipase enzyme. And this is like a self-cleaning mechanism that cleans the inside of the sebaceous gland wall. Under normal circumstances, your follicle can harbor oxygen, but your sebaceous gland is an anaerobic environment, which means that Cutibacterium acnes lives and thrives without oxygen. If you take a fish out of water, it asphyxiates, it can't breathe. No, I've never taken a fish out of water. But we understand that when we now create a different environment, we now asphyxiate that fish and it can't breathe, it's not too dissimilar that if you add oxygenation to the anaerobic environment of Cutibacterium acnes, you force its degeneration. So let's have a look at the acne cycle. With acne, what's going to happen based on a variety of factors is we are going to see the sealing off of the top part of the follicle. It's a lot like the lid of a Tupperware container, seals the air off. Now, this is going to contribute to clogging and congestion. The formal term medically for clogging and congestion is called retention hyperkeratosis. When this begins to seal off the mouth of the follicle, this now makes the follicle anaerobic. So in this case, this invites the C. acnes bacteria, which should live in the sebaceous gland, to now take up residency in the follicle where it should not be. And the only reason why it's moved is the follicle is now newly anaerobic due to retention hyperkeratosis. What occurs with this process is when we increase Cutibacterium acnes, we also begin to recruit another type of bacterium, and it is called Staphylococcus epidermidis. Staphylococcus epidermidis is resilient. So first thing, if you do treat for acne stage 1 comedonal, acne stage 2 papulopustular, acne stage 3 nodular cystic, on day 2, you will get a phone call that says, "Hi, I think you made my skin worse." And your answer is going to be, yes, as I told you during the consultation. Now that we've instantly killed the Cutibacterium acnes as simply with the insertion of 1,920 puncture channels per second with our Dp4 device, this kills the Cutibacterium acnes, but it will still take a few days to resolve the associated Staphylococcus epidermidis. So with this, we can effectively treat without spreading P. acnes or Cutibacterium acnes because it lives here in an anaerobic environment. So as such, we now see new opportunity and new horizons for the treatment of stage 1 comedonal acne, stage 2 papulopustular acne, stage 3 nodular cystic acne. However, I don't recommend that you treat acne stage 4, which is acne fulminans or acne conglobata. You will need to undergo probably a drug combination therapy, probably an oral isotretinoin. In this case though, your aim is to try and deliver no blood pink, no blood red skin. However, as you Dp4 over the top of an active acne lesion, you will create some localized blood. I'm always fascinated by advertising on television when it comes to acne gels and acne treatments. So commonly on these ads, which are aimed directly for the not so educated teenage market, what they're normally going to show is this follicle here, and if you have acne, then you have all of this dirt, clogging, and congestion within your follicle. So with this, if you use our brand new acne product, what it's going to do is penetrate into the follicle and it's going to remove all of this clogging and congestion, and you will have perfectly clear skin. There's a big problem with this drawing. Epidermis, dermis, hypodermis. You would be drawing blood. So retention hyperkeratosis is not this. Retention hyperkeratosis, clogging and congestion, actually comes from the top down. So this is the reason why you only need to work into granulosum or into spinosum. You don't need to be working down into the dermis. So your visual endpoint will be no blood pink to no blood red skin. You will have some localized blood on active papules, pustules, nodules, and cysts. Not a problem, so long as the whole face is not covered in blood. From our successful treatment of acne, we can also successfully treat all forms of hyperpigmented conditions. For epidermal hyperpigmentation, it is characterized through speckled pigment that tends to be yellow, gold, tan in undertone on all Fitzpatricks. With this, epidermal pigmentation is often associated with faculative hyperpigmentation, uneven skin tone. We then move into lentigines or clusters of free melanin and age spots within spinosum and basal layer, moving into post-inflammatory hyperpigmentation, and then also consideration ephyllides or freckles. If there is epidermal melasma, it will be highlighted, number one, through color. Yellow, gold, orange, tan in undertone. And in the case of epidermal melasma, you will have a solid interior and a speckled exterior. However, in the case of dermal hyperpigmented conditions, your pathophysiology or your cell that's not functioning is not just the failing relationship between melanocyte and keratinocyte, it's also your clusters of melanophages deeper down in epidermal junction and collecting around these vertical vessels here. So this now creates what we call mixed or dermal hyperpigmentation. How do I identify? The color is going to be more blue, green, gray in undertone. We call this the Tyndall effect. For example, if I have a look at the vessels on the back of my wrist here, they're blue. Does this mean I'm blue-blooded? No. But the play on light creates a change of color. So the clusters of melanophages farther down within the skin will be blue, green, gray in undertone. And you'll also notice that the macules or solid pigment are identified by a solid border and also identified by a speckled interior. So visually, we can see the difference whether something is epidermal hyperpigmentation or whether something is dermal hyperpigmentation. If we can treat and target, particularly through the release of melanocyte growth factor, keratinocyte growth factor, when there's too much pigmentation, hyper, then we can also treat and target when there is not enough, hypopigmentation. So this is the same area, no blood, red skin, that you will treat and target for Goutard hypermelanosis, ultraviolet infused. That you will treat also for post-inflammatory hypopigmentation, chemical leukoderma, and also as part of drug combination therapies, through this region here, you can treat forms of vitiligo vulgaris or generalized vitiligo, and also its subcategory, acral vitiligo. So we understand with placement of cell groups, their malfunction. We understand with a visual endpoint, but also identifying whether it's epidermal or dermal, that we can now create the perfect endpoint based on what you see, not based on what you're dialing up within your device. So moving on from the epidermis, let's have a look at what's happening with the dermis. For all of your collagen induction therapy procedures, you must see blood. To repeat, there is no such thing as a baby Dp4 procedure. You can't get stimulation and activation of fibroblasts if you're directly treating and targeting a corneal site. So we understand that you must see pinpoint blood as a minimum. So pinpoint blood for your anti-aging, your skin rejuvenation procedures, but also pinpoint blood as a minimum for treatment of scars. When we have a look at scars, we have a couple of categories to take into consideration. First category is when we have atrophy, and we will refer to these as atrophic. The most common reason why your patient will have atrophic scars is post-acne. And the reason why post-acne scars occur links back to the role of lipase enzymes. You can imagine that the wall inside the sebaceous gland here is extremely fatty. And so the role of lipase enzymes actually helps to digest and break down that thickened, accrued lipid that we see inside the sebaceous gland. I liken this, if you are frying bacon on the stove, with your pan, you can't just run it under cold water and put it back into the cupboard. You're going to need dishwashing detergent to break down the grease, and you will probably need a scourer to clean the pan correctly. This process is not too dissimilar to a lipase enzyme. it's able to treat effectively the build-up of lipids within the sebaceous gland wall to now enable a self-cleaning mechanism. The problem is, though, when you seal over the follicle, retention hyperkeratosis, not only does this mean the movement of Cutibacterium acnes from where it should be here in the sebaceous gland, but also what removes into here is the release of lipase enzymes. This is problematic. If we describe your sebaceous gland as being the pan that you have just created a big fry-up, if we consider your sebaceous gland to be like the pot or like the pan or the oven dish that you bake something with hard stuck-on melted cheese, then the role of a lipase enzyme works successfully. However, the inside of your follicle is a lot like your great-grandmother's Limoges bone china. So if you then use a harsh dishwashing detergent and then scrub with a scourer, you're going to break the porcelain. So when lipase enzymes move into the follicle, they begin to attack and redigest the triglycerides, but also attack the follicle wall, now contributing into your post-acne scars. So with post-acne scars, we consider that they are generally atrophic. We consider first rolling, wave-like undulations, typically following acne stage 2. We then see box scar, a square-like indentation into the skin, typically following acne stage 2 and 3. We then take into consideration ice pick scars, which is a triangular-like indentation into the skin. There's two reasons why these occur. Number one is acne, but number two is seborrhea, the genetic predisposition for an excessively oily skin. So it's not too dissimilar to a dilated pore. Many people will tell you that an ice pick scar is deeper and more severe by contrast to a box scar. Not necessarily. If you look at the shape of these, and if you were to illuminate with light, you'll find that this bottom section tends to harbor more shadow, whereas the light bounces easier in a boxcar scar. That is why an ice pick scar generally looks deeper, but it's a play on light with this. The other type of atrophic scar that we take into account is called an anetoderma, otherwise known as an anetodermic. And it's a rounded pockmark. The most common reason is following chickenpox. You will see it following a smallpox inoculation, but also, particularly during COVID times, we began to see a very big rise in syphilis. And with undiagnosed syphilis, it will begin to create atrophic anetodermic scars on the skin. The next areas of consideration are hypertrophic scars. All keloid scars are hypertrophic, but not all hypertrophic scars are keloid. To explain, a hypertrophic scar is where you have trauma that creates an overgrowth, but it remains within the boundaries of the initial trauma. By contrast, a keloid scar is where you have trauma, but it grows above and beyond the boundaries of the initial trauma. Very different. So, as part of diagnosis with your scars, if they have a red, blue, or purple undertone to them, that is your visual cue that there is still some relative vascularity within papillary dermis. So if you're rolling, boxcar, ice pick, anetoderma, hypertrophic scars have a red, blue, or purple undertone, treat here. However, for older scars, if they are white or silver, in Latin we call this alba, or if they are very dark purple or very dark brown, in Latin we call this cerulean or nigri, then this is a sign that this vascularity has either been pushed farther and farther and farther down due to abnormal healing, or doesn't exist at all if you consider something like a burn contracture scar. So in that case, that's the only time that you ever need to target down to the hypodermis for a mechanical scar revision. But if you want new collagen at an 85% potential, this is your area for increasing new collagen production. Not here, but not here. It's also not too dissimilar if you consider striae. Striae distanceae, changes in weight fluctuation. Striae gravidarum, pregnancy. Striae atrophicae, which comes from cortisone and reaction to this. So with this, if again your striae are red, blue, and purple in undertone, aim here, pinpoint blood. But if they're white, dark purple, or almost very dark brown, then you can aim down to the hypodermis. For treatment of vascular disorders, telangiectasia, stage 1 rosacea, erythema telangiectatic, stage 2 papulopustular, stage 3 nodular cystic, we understand that the condition itself is an overangiogenesis of these papillary capillaries. It's fueled by inflammatory bradykinin peptides. It sees the release of matrix metalloproteinases, collagenase and elastinase, which begin to eat and attack the extracellular matrix, but we also see an overkeratinization, which then begins to thin the epidermis. If I can see your vessels in papillary dermis, then you have a very, very, very thin skin. As such, you can treat rosacea as part of your Dp4 treatment protocols. However, note that your visual endpoint is not just pinpoint blood, but because their skin is thinner, you will be able to draw pinpoint blood at a more superficial depth. Not a problem. You just need to know and understand how to customize, how to create a visual endpoint, and why you are drawing that visual endpoint. The role and the success to balance angiogenesis, to redensify the dermis, and to balance keratinization now provides an innovative response for treatment of all forms of rosacea. In the case of stage 3 phymatous rosacea, where there is rhinophyma and phyma on the forehead, on the chin, you may require a drug combination therapy. Finally, for the hypodermis, we understand that your visual endpoint is going to be a moderate release of blood. You can treat here if you need to mechanically revise scar tissue that is this deep. You can treat here if your scar is white, silver, if your scar is dark purple, or if your scar is dark brown. This is also the case if you are treating for striae. Please note that under any circumstances, all of your keloid scars must be part of a drug combination therapy. A stabilized hypertrophic may not require, but a keloid scar will require a drug combination therapy. We also consider that these hypodermic vessels, which are larger in size, but also less frequent than our papillary vessels, are the same vessels that enable the delivery of nutrients, the delivery of hormones and growth factors to facilitate hair growth. Firstly, your Dp4 will not make you grow hair in unexpected places by itself. Hormones are responsible for that. Secondly, your Dp4 becomes a facilitator and a combination therapy for your alopecia procedures. PRP, drug combination therapy, exosomes. In order to achieve success, you must have an active follicle. There must be a bulb. If the follicle is dormant, this is hair transplantation time. However, we can see results as part of combination therapies for tractional alopecia, cicatricial alopecia, androgenetic alopecia. In this case, the patients must commit to a lifetime application of a follicle maximizer. This drug is minoxidil. So no matter how many procedures you undergo, if the follicle minimizes, then the hair is going to thin, and then the hair will develop from being terminal back to vellus. We can also treat for telogen effluvium, which will often require a follicular maximizer, such as minoxidil, and for stabilized for at least 6 months, alopecia areata. So with this simple summary, we can now see and understand the value of your Dp4 for more than just collagen induction therapy. We can see the value of your Dp4 into the epidermis, into the dermis, into the hypodermis. We can see the value of understanding that how you treat is not mathematically, how you treat is what you see. Corneum, no blood, no color change. Granulosum, no blood, pink. Basal spinosum, no blood, red. Epidermal junction, very superficial papillary dermis, the occasional pinpoint blood. Mid-papillary dermis, moving down to reticular, consistent pinpoint blood, and then moving on down to the hypodermis, moderate release of blood. So with this process, simply determine which indication, which cells have gone wrong, what is their location, and how is this going to influence what my visual endpoint is? What do I need to see?